This video will demonstrate our workflow for a MAKO total knee arthroplasty. There are many ways to do this. In general, we approach this with the tibial cut first and then proceed to the femoral cuts. The guide pins for the femoral array after a standard medial parapatellar arthrotomy are placed medially aimed directly back at the surgeon's chest, and I'm standing laterally in this case. The checkpoint is then inserted just above and slightly proximal. It's very important, we'll show later, to keep this away from that anterior chamfer cut. The arrays are then assembled. It's important not to touch the discs because blood or liquid on them can interfere with their function. We'll secure the whole array first and then adjust the rotation until it faces the camera. Then tighten and secure, making sure that the teeth are not cross-threaded. We'll then move to the tibia, and these are placed first at the bottom of the incision, directed anteriorly to, but ideally not through the back cortex, where they can risk neurovascular injury or fracture. The guide is inserted, an additional pin is in place more proximally. The tibial checkpoint is in place just slightly more proximal and medial to that. And with all of this being satisfactory, we're ready to begin our registration. Here the tibial intra-incisional guides being attached, again first to the pins, then setting the rotation and securing those with the wrench. If needed, an assistant can hold these while they get tightened into place. Hip is then taken through a range of motion to identify the hip-knee axis, and the blunt probe is used to identify first the medial and then the lateral malleolus. Both checkpoints are then doubly confirmed, femur and tibia. Next we'll change to the sharp probe, which will start off in a suprapatellar location, and then evaluating the screen, we'll collect these series of data points to confirm the CT map relative to the actual anatomic findings. This can be done either with a foot pedal or with use of an assistant. Once all of the checkpoints are collected, the same process will be repeated for the tibia, and the blue buttons will validate the model. The computer will then notify you to resect the osteophytes prior to doing any gap balance. The knee is brought to full extension, and in this case registers an 8 to 9 degree deformity. We then determine how correctable this is. In this case it is partially correctable to 3 degrees of varus, and there is about a 7 degree flexion contracture, which is not correctable. The knee is then brought into low flexion and stressed medially and then laterally. The knee is then brought into a low angle of flexion, and we see here that there is medial tightness and relative lateral laxity. The knee is then brought into flexion around 90 degrees, and there again is significant tightness medially at 90 degrees. This is formalized and captured with a small slotted spoon, and this demonstrates significant tightness medially, and then moving to the lateral side, there's relative lateral laxity. Attention is then turned to the planning screen. Because the knee is tight both in flexion and extension, we'll start with 2.5 degrees of varus on the tibia, and then we'll add some additional varus maybe later to the femur. We're going to increase the distal femoral cut to open the extension space. It's okay to be a little bit looser laterally than medially, but we are going to want to roughly balance this. We can then start to anteriorize the femur, and this will create more laxity and flexion, which is symmetrical, but some external rotation will help make this more symmetrical, and we'll take this up to about 3 degrees. We'll notice that the gaps are starting to balance very nicely, where it's equally balanced in extension, a little looser in flexion on the lateral side. We'll then go and check the flexion of the implant to ensure that it's not going to notch. We'll leave this at about 2.5 to 3 degrees of flexion. The screen will then be changed, and we're going to start to assess the concentricity first of the posterior medial cut, wanting the implant to be slightly smaller to open this space, and then we'll confirm laterally, where the implant will often be a bit larger, filling that flexion gap posterior laterally, and that's nicely demonstrated here. We'll then check the patellofemoral runout and see that the tracking of the implant is overall matching the groove, and in this case it is. That's the central middle portion. We'll also look at the onlay of the tibial plate, and we'll see here that we might cut for this size tibia, but with that posterior lateral overhang, we may opt to downsize based on our tibial prep. Again, confirming the balance, and then the size of the cuts will be assessed. There is quite a large cut in the flexion space medially, but given the amount of tightness there, we felt this was acceptable. The checkpoint will then be used again first on the tibia, and we'll complete the tibial cut. A lap sponge is used with two retractors which are protecting the MCL. There are no posterior retractors in place. We're trusting the haptic stop, and it will leave a kerf of bone around the PCL in this cruciate retaining approach. Generally, when making the saw cuts, we'll open the entirety of the cut first, and then I'll start to work once I'm visually past the patellar tendon to complete the resections deep posterior laterally and posterior medially. This tends to cause less binding of the saw. For the sake of time here, we won't demonstrate all of the cuts, but attention is then turned to the femur using the same saw blade and orientation. The anterior cut is made, the posterior cuts are made, and the anterior chamfer cut is made. Curved osteotome is then used to remove those posterior cuts, as well as the anterior cuts, while the assistant or the scrub tech is changing the saw blade to the secondary blade, which is necessary to make the distal femoral cut and the posterior chamfer cut. I'll do some additional checks here, and this is an important time to notice how close that you can get with that cut to the checkpoint. That timing works out pretty well. The additional two cuts are made, those cuts, and then the tibia cut are removed. Knees brought into extension, and a lamina spreader is put into place first on the lateral side, allowing for meniscal resection medially, and then switching that, allowing for meniscal resection and injection of the posterior capsule. This being satisfactory, the trials are then placed. The trials are then subjected to the same testing with the arrays in place, and if those look good, we'll move to final implantation. In this case, the femur and the tibia have been implanted, and two Hohmann retractors are used. A lavage will be put into place after final trialing. The final poly will be put into place. Thank you.